Thank you so much for taking time out of your day to join us. Whether you're a seasoned hospice clinician, an agency administrator, or someone newer to the world of hospice care, you're in the right place. Today, we're diving into something that will affect every Medicare-certified hospice agency, the HOPE assessment, which officially goes live on October 1st of 2025. Let me introduce myself before we jump in. My name is Terrence J. Finesse, and I'm the product manager at Alora Healthcare Systems. I've been part of the Alora team for over 9 years, and I bring more than 25 years of healthcare experience in home health and hospice. So I understand how regulatory changes like this can impact your day-to-day clinical work, workflows, and your bottom line. I've got lots and lots of information to share with you today, so let's get started. Let's start by setting the stage for what you'll walk away with today. By the end of today's session, you should be able to understand the origin and purpose of the HOPE assessment, identify the implementation timeline and compliance requirements, explore the key differences between the current HIS process and the upcoming HOPE workflow, review the workflow and documentation expectations for one of the most critical changes, the symptom follow-up visit, how Alora is supporting agencies with tools, alerts, and structured workflows to help you stay compliant and efficient from day one. And I'll share some practical tips for agency readiness. Let's step back for a moment and talk about how we got here. HOPE stands for Hospice, Outcomes, and Patient Evaluation. And this isn't something CMS dreamed up overnight. In fact, the groundwork for HOPE started back in 2019, with a series of environmental scans, clinician interviews, listening sessions, and pilot tests. So why the change? CMS has long acknowledged that the hospice item set, or HIS, has significant limitations. It captures a narrow snapshot of data, often retrospectively, and doesn't give a full picture of the patient's experience or condition over time. HOPE is a response to that gap. It shifts the model towards real-time, patient-specific assessment. It's designed to be flexible enough to accommodate the complexity and uniqueness of each hospice patient, while still collecting standardized data that CMS can use for quality reporting through standardization, survey and certification, and eventually for refining future payment models and public reporting. So think of HOPE not just as a compliance tool, but as a shift towards measurable, patient-centered care at scale. Now let's talk about timing, because HOPE is quickly approaching. HOPE becomes mandatory nationwide for all Medicare-certified hospice agencies starting October 1st, 2025. That's the go-live date, but the preparation needs to happen long before that. My recommendation: aim to have your clinical and operational staff fully trained no later than the third quarter of this year. And that doesn't mean just knowing the assessment items. It means adjusting documentation workflows, rethinking how symptoms are tracked and followed up, and updating your internal policies. I want to stress this point. This isn't just a documentation update. It's a compliance shift, a staffing strategy adjustment, and in some ways, a redefinition of how hospice agencies demonstrate quality. Starting early is critical, not just to avoid survey findings or penalties, but to ensure your team feels confident and your agency remains centered on the compassionate, person-directed care that HOPE is ultimately meant to support. Let's dig into one of the biggest operational shifts: the difference in how and when data is collected under HOPE compared to HIS. Under the current hospice item set, or HIS, you're only responsible for submitting assessments at admission and discharge. That's it. 2 static points in time, often documented after the fact with minimal clinical depth. But HOPE introduces a very different cadence. You'll still complete an admission assessment, but then CMS adds 2 new required time points called HOPE Update Visits, or HUVs. The HUVs enable CMS to gather patient-level data during the first 30 days after a beneficiary elects hospice. HUV1 must be completed between day 6 and day 15 from the date of admission, and HUV2 must be completed between day 16 and day 30 from the date of admission. So depending on how long your patient remains on service, you can have anywhere from 2 to 4 required HOPE assessments. But here's where it gets a little bit more complex. Based on how your patient scores on symptom impact questions during any of the admission or HUV assessments, CMS may require an additional symptom follow-up visit, or SFV, to be completed within 48 hours of the original symptom impact screening. That follow-up visit becomes a required part of the HOPE assessment and must be documented as a separate encounter, not just an update to the original note. It also becomes a key compliance target, so your documentation must clearly show that a follow-up occurred, that the symptoms were reassessed, and that it was done within the required time frame. We'll go into SFVs in more detail soon, but it's important to understand now that HOPE isn't just more frequent, it's more dynamic and patient responsive. It's not just a timeline change, it's a mindset change for your clinical team. All right, now that we've looked at the timeline, let's talk about what's actually changing inside the assessment itself. This is where we start to see just how much more clinically rich and patient-specific HOPE is. We're moving away from a mostly administrative data set and towards an assessment with greater standardization and clinical relevance. Over the next few slides, I'll walk you through each major section of the HOPE assessment, what's staying the same, what's being added or revised, and what that means for your team's documentation practices. Before we dive deep into the HOPE sections, let's take a quick look at what we've been working with in the current hospice item set, or HIS. HIS has served us for years, but it's always had its limitations, especially in how narrowly it captures a patient's overall condition. Let's move to what's new and how it expands on these core areas. HOPE introduces a broader, more clinically detailed structure, and one of the most notable additions is a brand new section focused on skin conditions. This is a clear signal that CMS wants to move beyond administrative data and start capturing more holistic clinical indicators, elements that are highly relevant to both quality care and compliance. Let's start with the administrative section and work our way from there. Let's begin with an update to how we report the site of service at admission. In HOPE, item A0215 replaces the old A0205 field. And while the change might seem subtle at first glance, it reflects CMS's broader push towards clearer, more standardized language. Here's what's changed. CMS has revised the labels so that each option no longer starts with hospice in, which helps avoid redundancy and makes the form more intuitive. Item 6 was revised with verbiage to identify general inpatient, providing better clarity for those higher acuity admissions. Item 9 has been updated from the vague place not otherwise specified to the more recognizable routine home care. And lastly, item 99 was added for not listed or none of the above, giving agencies a proper catch-all option when none of the predefined categories apply. While these tweaks may seem cosmetic, they're actually helping us reduce interpretation errors and increase consistency in how care settings are documented, which becomes especially important when those data points start being used in future public reporting and payment models. Next up is a data element that's going away. In the current HIS workflow, we've been required to report the date the initial nursing assessment was initiated, A0245. Under HOPE, this item has been removed entirely. Why? CMS determined that this field wasn't contributing meaningful data to the hospice quality reporting program. So in an effort to streamline the assessment and reduce redundant documentation, A0245 has been eliminated. Now let's talk about a structural change in how demographic data is captured. Under the HIS, we've been using A1000 to record both race and ethnicity in a combined format. In HOPE, this is being replaced by two separate elements, A1005 for ethnicity, and A1010 for race. If you've completed assessments in OASIS or MDS, these fields will likely look very familiar. CMS is working towards standardization across all post-acute care assessments, and this change brings hospice into alignment with the rest of that framework. Breaking these fields into two discrete items improves reporting accuracy, enhances data interoperability across care settings, and ensures that patient-reported information is reflected clearly. Next, we have a new field that aligns hospice with long-standing standards in other care settings. A1110 has been added to the HOPE admission assessment to capture the patient's preferred spoken language and whether an interpreter is needed or requested for communication. Beyond compliance, though, this is about providing culturally and linguistically appropriate care. CMS is recognizing that communication preferences are not only a patient right, they're foundational to delivering person-centered care. Capturing this upfront helps ensure your team can deliver information, education, and emotional support in a way that the patient and their family can truly receive it. And that's at the heart of good hospice care. Let's continue with another adjustment CMS made to align hospice data collection with what's used in the MDS. The previous field, A1802, has been replaced with A1805 in the HOPE assessment. This item captures the patient's place of residence prior to hospice admission. There is a slight difference to the MDS, or minimum data set, used by SNFs for A1805. 09 for hospice at home, non-institutional, and 12 home under care of organized home health service organization were removed. CMS determined that 01 for home and community now sufficiently captures both scenarios, since in each case, the patient was still residing in a community-based setting. Now we come to a new data element in HOPE that speaks directly to the patient's social environment. A1905, titled Living Arrangements, is designed to capture where and how the patient is living at the time of admission, not just their address, but the type of living situation they're in. And here's the key coding guidance. If more than one situation applies, you must select the code with the higher numeric value. So for example, if your patient lives in an ALF, but shares the space with a spouse, you wouldn't select 2 for lives with others in the home, you would select 3, congregate home, because the care structure takes precedence. This field supports more accurate analysis of patient needs and helps CMS assess how different living arrangements impact hospice care delivery. A1910 is another new addition to the HOPE admission assessment, and it gives us a structured way to document the support system a patient has in place. This item captures the level of in-person assistance available from non-professional caregivers, meaning family, friends, or other unpaid individuals, not hospice or facility staff. The question is designed to reflect the patient's support at the time of admission, and it can be answered through an interview with the patient and/or caregiver. If neither is able to respond directly, clinicians are permitted to use available documentation such as referral information, the clinical record, or facility staff input to complete this field. This element provides CMS with data on caregiver availability, which has a direct impact on care planning, patient safety, and burden on hospice services. It's important to note that A1910, like all of the administrative section items that I've mentioned, are only captured during the HOPE admission assessment. Let's take a quick stop at section F for preferences. This section remains unchanged in the HOPE assessment compared to what we've seen in the HIS. This item is still only captured during the HOPE admission. Now let's take a look at one of the most clinically impactful sections of the HOPE admission assessment, the principal diagnosis. I0010 has been expanded to provide more specific coding options for the condition that's contributing most to the patient's prognosis. In the old HIS framework, options were limited, primarily cancer, dementia, or none of the above. With HOPE, CMS has expanded the list. You'll now see that they've added neurological condition, stroke, COPD, cardiovascular conditions excluding heart failure, and item 7 specifically for heart failure, liver disease, and renal disease. This added specificity supports better data collection. In Alora, selecting the principal diagnosis will trigger corresponding available local coverage determination, or LCD pathways, meaning you'll be able to document against the LCD guidelines for that diagnosis, helping you better validate terminal status and support eligibility. If you want to learn more about the LCDs for determining terminal status based on diagnosis, I've included a link in the reference slide. In addition to the principal diagnosis, this section now includes a multi-select list of comorbidities and coexisting conditions. You'll want to check any condition that's addressed in the plan of care or has the potential to impact care delivery. Do not include the principal diagnosis here unless the patient also has a secondary cancer. This section is collected only at admission, so accuracy at the start of care is key for eligibility documentation and care planning downstream. Section J brings us to a critical and deeply clinical new data element in the HOPE assessment. CMS has added a new item to assess whether death is likely imminent within the next 3 days. This item is coded during the HOPE admission and during both HOPE update visits, or HUVs, which means your clinicians may encounter it multiple times through the first 30 days of patient care. The goal here isn't to predict the exact moment of death, and it's not a formal prognosis. Instead, clinicians are asked to use their best judgment based on what they observe at the time of the visit. They are to determine whether signs suggest death may be approaching within 72 hours, with the day of the visit counted as day 0. And why does this matter? Because accurate identification of imminent decline helps CMS and hospice providers evaluate the timeliness and appropriateness of interventions, including pain and symptom management, emotional support, and family counseling. It's also a reminder that HOPE is shifting towards real-time care documentation, which means your clinician's bedside judgment now directly impacts quality measures. Next, let's talk about a new addition to HOPE's pain assessment structure, the identification of neuropathic pain, J0915. This item is assessed only during the HOPE admission assessment, so capturing it early is essential for care planning. The goal here is to ensure that neuropathic pain, which often requires specific pharmacologic or non-pharmacological management, is identified early so that interventions can be timely and effective. This is one of the many examples of how HOPE moves us to closer, real-time, symptom-specific care documentation, which not only improves compliance, but also patient comfort and quality of life. Let's take a look at J2040, the item related to shortness of breath, which has been slightly revised in HOPE. They've removed option C, which asks clinicians to specify the types of treatment initiated for shortness of breath. Why the change? Because that level of detail wasn't being used to calculate any quality measures, and CMS is aiming to streamline the assessment by focusing only on what drives reporting and meaningful clinical data. This item is collected only at admission, and it helps CMS evaluate how quickly and appropriately symptoms are managed at the start of care. Even though it's been simplified, make sure your documentation still reflects what interventions were provided, as that's essential for interdisciplinary care planning and survey readiness. All right, now we're getting into one of the most significant and clinically rich parts of the HOPE assessment, symptom impact screening. This is where HOPE shifts us from simply documenting the presence of a symptom to evaluating how that symptom is actually affecting the patient's life. J2050 asks whether a symptom impact screening was completed and the date it was done. And J2051 then measures the level of impact for each of the following symptoms: pain, shortness of breath, anxiety, nausea, vomiting, diarrhea, constipation, and agitation. The focus here is not how often the symptom occurs or how severe it feels. It's about how that symptom impacts the patient's comfort, function, and quality of life. And I want to repeat this again because it's very critical that your nurses understand how to respond to this question. It's about how that symptom impacts the patient's comfort, function, and quality of life. For example, a patient may rate their shortness of breath as mild in intensity, but if it's causing them to avoid speaking or withdraw from loved ones, it could still have a moderate or severe impact to their quality of life. This is where clinical judgment is key, and you're encouraged to factor in the patient's input, observations from caregivers and staff, and your own professional assessment. Now here's the regulatory hook. If any symptom is rated moderate or severe, CMS expects a symptom follow-up visit, and you must complete that visit within 48 hours for the HOPE assessment to be considered complete. That follow-up must be documented as a separate visit, and it's a new workflow that we'll dive into much further. So keep this in mind. Symptom impact is one of the most closely watched items in HOPE, both from a clinical and compliance standpoint. It's not just a question, it's a trigger. Let's talk now about what happens after a symptom is identified as having moderate or severe impact. That brings us to two new key data elements, J2052 and J2053, which together document the symptom follow-up visit, or SFV. J2052 asks if a follow-up visit was performed, the date it was completed, or if it wasn't, it requires you to select a reason why. And J2053 captures the new symptom impact rating during that follow-up visit. These fields are critical because CMS expects that any symptom identified as having moderate or severe impact must be followed up within 48 hours. And this visit must be clearly documented as a separate encounter. The SFV can be completed by a registered nurse, LVN or LPN, but it cannot be conducted during the same visit as the HOPE admission or HOPE update visit assessments that triggered it. That being said, it can occur later in the same calendar day as long as it's documented independently. We'll revisit the symptom follow-up visit workflow later in this presentation, but I want to emphasize now, this is one of the most visible and measurable aspects of HOPE from a compliance perspective. If you're not capturing follow-ups within the correct time frame or not documenting them clearly, it's going to affect your quality reporting and your survey readiness. We now move into section M. This entire section is new to hospice assessments and focuses on something we encounter frequently in the field but haven't formally documented in the HIS: skin conditions. Section M is required for both HOPE admission and HOPE update visits. So clinicians will be responsible for consistently evaluating and updating this information through the patient's first 30 days of care. MU 1190 asks whether the patient has any skin conditions, and MU 1195 documents the types of skin conditions present. And this is a multi-select item, so you'll check all that apply. This section helps bring hospice in line with what's already standard practice in home health and SNF settings, and it allows CMS to better assess risk factors, care needs, and potential safety issues for vulnerable patients. Building on the previous slide, MU 1200 captures the next logical step. What treatments are in place for the skin conditions identified? This is a multi-selection item that asks which interventions or therapies are active at the time of the assessment, specifically related to skin issues, ulcers, or injuries. You'll want to check all that apply, including treatments that are newly initiated or continued from prior care plans. CMS provides a clear definition of what qualifies as initiated. A treatment is considered initiated when your hospice agency has received the order and there is documentation that the patient and/or caregiver has been instructed to begin using the product, therapy, or intervention. This item is assessed during both admission and HOPE update visits, and accurate reporting here helps reflect clinical responsiveness to skin integrity issues and appropriateness of care interventions. This is also a good point to remind your team to verify verbal orders, update care plans, and ensure treatments are being both offered and explained at the bedside, because that's the level of detail surveyors may look for downstream. Moving into section N, medications, you'll be glad to know there are no structural changes here. The data elements related to medications in HOPE remain consistent with what we've been seeing previously. However, it's important to note that these items are not limited to the admission assessment. Under HOPE, all medication-related elements must also be completed during both HOPE update visits or HUVs. Even though the structure hasn't changed, the frequency has. So make sure your medication reconciliation and documentation processes are updated accordingly. Now we come to the final section of the HOPE assessment, Section Z, Record Administration. There's one new data element here that applies only to the HUV or HOPE update visits, and that's Z0350, the date the assessment was completed. This isn't just a timestamp. Z0350 represents the date when the entire HOPE update visit process is considered complete, and that includes any required symptom follow-up visits. So if your HOPE update visit triggers a symptom impact rating of moderate or severe, the clock doesn't stop until the follow-up is documented. Let's look at an example. You perform the first HOPE update visit on day 15. A symptom follow-up visit is then completed on day 17. In that case, Z0350 would reflect day 17 because the HOPE update assessment wasn't completed until the follow-up was performed. Why does this matter? Because the 30-day submission deadline for each HUV is calculated from the date entered in Z0350, not the date of the HUV itself. So this plays a direct role in timeliness compliance for HQRP reporting. And agencies need to be diligent in tracking follow-up timelines and ensuring assessments are fully closed out. And speaking of timelines, let's discuss if and when you should use the HOPE assessment versus the HIS assessment. Let's start with the simplest scenario. If a patient is admitted and discharged before October 1st of 2025, your agency will continue to use the current hospice item set, or HIS, to complete both the admission and discharge assessments. The rule is simple. If everything occurs before October 1st, stick with HIS. Now let's look at the most straightforward HOPE scenario moving forward. If a patient is admitted on or after October 1st of 2025, then the entire HOPE framework applies. That means your agency will be responsible for completing a full HOPE admission assessment, HOPE update visit 1, HUV 1, between days 6 and 15, HOPE update visit 2, or HUV 2, between days 16 and 30, and the HOPE discharge assessment. You'll also need to document symptom follow-up visits, or SFVs, if any symptoms are rated moderate or severe during any of those assessment time points. It's good to note as well that based on the length of stay, you may or may not have HUV visits. Patients that were admitted before October 1st of 2025 and are discharged after October 1st, 2025 are not subject to HUV assessments, but would need to be discharged using the HOPE discharge assessment. Now let's talk about who can complete a HOPE assessment. Per the hospice COPs, it is at the discretion of the hospice agency to determine who can accurately complete the HOPE assessment. Each person completing any portion of HOPE should provide a signature in Section Z for record administration. The hospice agency is responsible for the accuracy and completeness of information in the HOPE assessment. Most agencies leave the responsibility to the RN to complete it as best practice. Now, if you recall, there are additional time points to be aware of when completing a HOPE admission or HUV: symptom follow-up visits. And before we dive into how symptom follow-up visits, or SFVs, are triggered and documented, let's establish what they are and why they matter. A symptom follow-up visit is a required in-person visit that must be completed when certain symptom thresholds are met during a HOPE assessment. Although it is not itself a HOPE assessment, it becomes essential to completing either the HOPE admission or HOPE update visits. CMS designed the SFV to ensure that patients with moderate or severe symptom impact receive timely follow-up care. This visit serves as clinical verification that appropriate symptom management is being addressed in real time. While we'll look more closely at the trigger conditions on the next slide, the key point here is this: the SFV is not optional once triggered. It is a compliance-sensitive time point, and its timely documentation is a core component of the HOPE framework. If your agency's clinical teams aren't trained to recognize when a symptom follow-up is required or aren't clear on how to document it, you risk incomplete assessments and quality reporting deficiencies. Let's now take a closer look at how SFVs are triggered and why CMS is treating them as such a high-stakes indicator. Symptom follow-up visits are not triggered randomly. They're directly tied to the results of item J2051 in the HOPE assessment. This item measures symptom impact across multiple domains. If any of the pain or non-pain symptoms are rated as having moderate or severe impact, a follow-up visit is required. CMS views these symptoms as priority indicators for follow-up intervention. And this is where the SFV comes into play. And here's how the timing works. The day the symptom impact is assessed is considered day 0. The symptom follow-up visit must be conducted within 48 hours of that assessment. It may occur later the same day, but not as part of the same visit. In other words, a nurse cannot complete a HOPE admission or HOPE update visit and then document the SFV within that same encounter. It must be a separate, in-person clinical visit performed by an RN, LPN, or LVN. If you were following the HOPE assessment progress over the past year, you may have noticed they changed the name from symptom reassessment visit to symptom follow-up visit. The reason they did this was to accommodate allowing LPN or LVNs to complete the symptom follow-up. CMS is treating this requirement seriously. In fact, your agency's ability to perform and document timely symptom follow-ups will directly impact compliance and be reflected in future quality measures. The good news is, timely symptom follow-up already aligns with existing hospice best practices. HOPE just brings that expectation into the national reporting framework. So what happens during the symptom follow-up visit, and how should it be reflected in the HOPE assessment? During the SFV, the nurse conducts a focused reassessment of symptom impact, and that reassessment is documented in 2 specific HOPE data elements: J2052, the date the symptom follow-up visit occurred or the reason it wasn't completed, and J2053, the updated symptom impact ratings based on that visit. Here's where it becomes a compliance issue. If the symptom follow-up visit is completed after the 48-hour window, you are no longer compliant and should not update the HOPE assessment with that visit. Instead, in J2052, you'll document that the follow-up was not performed within the required time frame and select the appropriate reason why. This should disable the ability to respond to J2053. Now let's say the follow-up visit does occur on time, but the patient still reports moderate or severe symptom impact. In that case, best clinical practice suggests performing another symptom follow-up visit. Even though it's not required for HOPE, it will not update the HOPE assessment, and it won't be reflected in quality measures. That said, from a care perspective, it's the right thing to do, and it reflects the spirit of HOPE, real-time, patient-centered symptom management. Ultimately, CMS isn't measuring your ability to improve the symptom impact. They're measuring your ability to recognize when symptoms matter and respond quickly. And that brings us to how HOPE symptom impact feeds directly into two new quality measures. Let's take a step back and look at the big picture. When we talk about HOPE and how it affects your agency, we're really talking about your performance within the Hospice Quality Reporting Program, or HQRP. CMS currently uses three main data sources to create and report hospice quality measures: claims-based measures, hospice CAP survey data, and beginning soon, clinical assessment data submitted via HOPE. HOPE introduces two new process measures, both tied to how your agency handles symptom impact. Number one, timely follow-up for pain impact, and two, timely follow-up for non-pain symptom impact. These measures will reflect the percentage of patients who had a moderate or severe symptom impact rating during HOPE and who received a documented in-person follow-up within 2 days. These measures don't assess whether the symptom impact improved. They assess whether your team acted quickly and documented it appropriately. And while these measures will be tracked internally starting October of 2025, CMS does not anticipate public reporting before the 2028 reporting fiscal year. So we have time to adapt, improve, and get comfortable with the new process. But make no mistake, this is coming and it will be visible to the public in the years ahead. And speaking of timeliness, let's talk about HOPE submission deadlines. Just like with the HIS, there are firm timelines for submitting each component of the HOPE assessment to CMS, and the rules differ slightly depending on the assessment type. Here's the breakdown. HOPE admission must be submitted within 30 calendar days of the admission date. HOPE update visits, or HUVs, must be submitted within 30 calendar days of the date the assessment was completed. That's Z0350, which should include any symptom follow-up visit information if applicable. HOPE discharge assessments are due within 30 calendar days of the discharge date. And just like with the HIS, failure to meet these timelines comes with a serious consequence. If your agency doesn't submit at least 90% of HOPE assessments on time, you may face a 4% reduction in your annual payment update. That 90% compliance threshold is not new. It's the same standard CMS applied during using the HIS. But with the added complexity of symptom follow-up visits and new time point dependencies, it's more important than ever to have internal workflows, audit tracking, and EMR support to help your team stay on top of deadlines. We'll show you how Alora helps manage all of that next. As a hospice EMR, we're not just aware of HOPE, we're actively preparing for it alongside you. We're rolling out a series of features specifically designed to support the clinical and operational demands of the HOPE assessment. Here's what you can expect. For starters, clinicians will be able to schedule a symptom follow-up visit directly from the HOPE assessment when a moderate or severe impact is identified. We'll also have validation rules to prevent assessments from being locked unless those required SFV elements have been addressed. And there's more. If a follow-up visit is performed, Alora will allow the clinician to update the original HOPE assessment based on that visit. The system will even import the follow-up nurse's signature into Z0400, so the HOPE record is actually signed off by all contributing staff. We're also giving agencies the ability to flag nursing visits as symptom follow-up visits. When that's done, the visit note will automatically include J2053, SFV symptom impact, and responses can directly update the corresponding HOPE record. No duplicate entry required. You'll have access to a dedicated widget on your dashboard to track all symptom follow-up activity, whether it's scheduled, pending, or ready for assessment completion. It will be fully actionable, so you can jump directly to where attention is needed to stay compliant. And as always, we're committed to keeping your agency informed and supported every step of the way. As we finalize the HOPE enhancements, we'll be hosting a live customer webinar, provide training resources, and ensuring our support team is fully equipped to guide you through a smooth and successful transition. Our job is to make sure your clinicians can stay focused on patient care, not chasing documentation requirements. HOPE may be complex, but with the right tools in place, it doesn't have to be overwhelming. So by now you may be thinking, what should I be doing today to get ready for HOPE? Let's break it down to a few clear, actionable steps you can take right now to position your agency and your team for success. First, download and read the CMS HOPE Guidance Manual. This is the foundation. It outlines the assessment structure, item-by-item definitions, and guidance for responses. Second, take advantage of CMS's Train the Trainer program. It's designed to give clinical leaders, educators, and quality managers a deep understanding of how HOPE works and how it impacts hospice care. I've included a link to these items in our reference slide at the end. Third, begin educating your RNs and interdisciplinary team members now. Focus on the big shifts like symptom impact scoring, HOPE update visit timeframes, and symptom follow-up visit requirements. Fourth, consider implementing symptom impact screening now, even if informally, if you're not already, so your clinicians get used to identifying when a follow-up visit within 48 hours is appropriate. CMS has already identified this as best practice within high-performing hospice agencies. And finally, confirm with your EMR partner that the workflows, dashboards, reminders, and validations you'll need will be in place and be ready to go. These steps will help you stay ahead of the curve and keep your team focused on what matters most, delivering compassionate, high quality, and compliant end-of-life care. Here are some key resources to support your ongoing preparation for HOPE.